Hello, my name's Simon Harrison, and I'm the chair of the Medical and Scientific Advisory Group at Myeloma Australia, and I'm also a myeloma doctor at Peter MacCallum Cancer Centre. So, as you probably know by now, myeloma is a cancer of some of the blood cells called plasma cells that live in the bone marrow and normally produce antibodies. These become damaged, and the genetic damage in these white cells produces an abnormal malignant plasma cell that produces a nonsense protein called an M protein that we can detect in the blood, and is often a way in which we can look for myeloma without doing a bone marrow. The proteins in the blood are called M proteins, and these are structured like a normal antibody, so they look like a Y shape. And the bits at the top of the Y are the elements that can detect antigens on the surface of bugs to prevent infection or cancer cells. And the big parts of these molecules are called heavy chains, and that's where the G, M, A, or E name comes from. And then the small bits are called light chains, and they're called kappa and lambda. And so that gives you a way of understanding when people say IgG kappa, that's what they're talking about. It's the structure of the molecule that your myeloma is making. I'll talk about light chains in a bit more detail in a minute. When we do a blood test looking for the paraprotein or the M protein in the blood, you can see here in blue, you get this nice separation and curve to the graph of the normal proteins that are in your plasma, in the liquid part of the blood. You can see in yellow, in the gamma region, you can see this very high peak, and this is the nonsense antibody that the myeloma cells are producing. And again, it's called either a paraprotein or an M protein, standing for myeloma protein. Small fluctuations in these levels don't mean a huge amount because the test is not that sensitive. And so there has to be a significant level in the blood, such as 5 grams per liter, to make a diagnosis of myeloma. And also somewhere between 5 and 10 grams per liter for us to say the myeloma is changing significantly and might need to have a change in treatment or initiate treatment. There are some patients who don't make any protein, and these could either be that they're making only light chains, which we'll talk about in a minute, or they're making no proteins at all, and that's called non-secretory myeloma. And that's quite difficult to monitor over time and requires more frequent scans and bone marrow tests. Here we can see light chains in yellow, which are the small parts on the side that combine with the heavy chain to form the antigen binding site. Light chains are produced in normal people, and they can be detected in everyone's blood. And the kappa and the lambda are usually about the same level in normal people. The light chains are quite small and can be filtered through the kidney, and they appear in the urine. And this used to be called this is called Bence-Jones protein. And this was a traditional way in which we used to detect myeloma as one of the very first ways in which myeloma was discovered over 100 years ago. To measure the light chain in the urine, you have to collect urine for 24 hours. That's a bit more difficult. And the light chain in the blood has to be above a certain threshold for it to go into the kidney and not be reabsorbed. Therefore, measuring the light chain in the blood is much more sensitive and accurate. And the light chain can change much more quickly than the heavy chain because it's excreted through the kidney very quickly. So this is the enemy, myeloma cells in the bone marrow. And you can see these big fat cells with a very large nucleus, the purple blob in the center of the cell. And then you can see the cytoplasm, the lighter color of tissue surrounding the nucleus. And then there's a very light area you can see, which is the factory of where the proteins are being produced. And this is much more obvious in myeloma plasma cells than in normal plasma cells, but also in other normal white cells. One of the things as doctors we look at is the nucleus Normally, this is a very dark color and very uniform, whereas here in this uh, micrograph of the bone marrow, you can see that the cytoplasm is pretty open. There's lots of lighter areas, and that's telling us that the cell's very active and producing lots of proteins. A bone marrow is performed by putting a small needle and sucking some liquid out from the back of the pelvis. And then we take a small piece of bone using a different kind of needle. And so this can be done with a little bit of sedation to make it more bearable for the patient. But it's a very important tool for us to A, make the diagnosis, and B, to perform very complicated genetic tests on the bone marrow to see how the disease is likely to behave in the future. And I'll talk about genetics in a little while. So one of the things that we need to decide when we meet a patient with a protein in the blood and plasma cells in the bone marrow is, do they need treatment? And one of the ways we sort this out is to try and work out, is the myeloma causing any damage? And so that's where the CRAB features come in. And so patients with a high level of calcium in the blood are deemed to need some treatment. Patients who have abnormal kidney function, usually because of light chains being stuck in the kidney, would also need treatment. Low hemoglobin or anemia is something that tells us that the myeloma is pretty active, either taking up lots of space in the bone marrow or affecting the kidneys that normally produce the hormone to tell the bone marrow to make red blood cells. And then one of the most common reasons for patients to seek medical attention is they have either bone pain or they have a fracture. And so the presence of bone disease or lumps outside the bone marrow that can be picked up on scans and x-rays are very important ways in which we can decide patients need treatment. When we're looking at the bones in patients with multiple myeloma, we can use a number of different techniques to see if the bones are damaged. Historically, plain x-rays have been the main way in which we've done this. And so here on the left, you can see little dark patches in the skull. This is called a pepper pot skull and is a classic feature of multiple myeloma. You can have disease in the long bones, and here you've got these very dark open holes in the bone and expanded areas of bone with a fracture through it in the tibia, one of the big bones in the lower part of the leg. And then you can do CT scans and looking for holes in the bones in the spine. And as adults, as the bone marrow really lives in the spine, the ribs, the pelvis, the sternum, and the tops of the long bones. And so you can see that these features can be relatively easily picked up on these imaging modalities. More recently, we've been using MRI scans to look at the soft tissue component of either the bone marrow or disease outside the bone marrow. In the right-hand panel, in the top left-hand corner, you can see an area of dark as illustrated by the arrow that shows it an infiltration of the bone marrow. And on the right-hand top panel, you can see a light area using a different setting on the scanner. And this tells us that these areas of the bone marrow have been infiltrated by the myeloma. And here you can see a patient who has quite extensive disease, both in the bones, but also in the liver, particularly. And this is a relatively aggressive feature of multiple myeloma, that it can live outside the bones and is quite unusual at the start of the journey, but becomes more common the more treatment patients have. And you can see over time that we managed to get rid of some of the myeloma, but the areas, particularly in the liver, were very difficult to treat until we used quite aggressive therapy and a bone marrow transplant followed by CAR T-cell therapy really brought this disease under nice control. So the PET scan uses radio-labeled glucose that's injected into a patient, and then you have to wait a few hours while the cells that are replicating quickly take up the glucose compared to the normal tissues. And that's why the areas of myeloma and also other cancers can light up in these dark areas, as shown on this scan. You can see particularly on the scans to the right-hand side where there's not much myeloma, that other tissues light up. And so that's organs that use glucose as a source of energy predominantly. So that's the brain, the heart, and then the kidneys excrete the dye, and so that can light up the kidneys and also the bladder. So these are the sorts of tests that we do for patients we think have myeloma to sort out whether that's the right diagnosis or not. And the most important element of that is to meet the patient and take a very thorough history of what's been going on and what's happened in the past, but also examine the patient. We do a blood count, sending it to the hematology lab. We do some biochemistry testing to see what the kidney and liver function's doing. We then also send off the paraprotein and the light chain tests. We do a bone marrow, as I talked about before, and then do the imaging to complete the staging. When we send off the full blood count, what we're looking for is what's the level of hemoglobin in the blood? Do they have anemia? Are there other features of the hematology system working properly in terms of your white blood cell count, the individual types of white blood cells, and the little cells in the blood called platelets that stop you bleeding? Are they at normal levels or are they reduced? When we look at the blood down the microscope, one of the classic features of myeloma is called rouleau, and this looks like a stack of coins, and the red cells sit on top of each other. And this is driven by the high level of protein in the blood, causing the cells to kind of line up in that way. More rarely, we look at are there any myeloma plasma cells in the blood? And this has become increasingly more important as the treatments have got better, as this is an aggressive or high risk feature. And so this may change the treatment required by a patient if they have plasma cells in the blood rather than in the bone marrow. We use this information in combination with some of the other tests like beta-2 microglobulin, albumin, and LDH to put into a calculator to generate a score to say whether a patient has standard risk myeloma or high risk myeloma, and therefore that may change the treatment available. And then in the middle is a category of intermediate risk where you're neither high risk or low risk. And this gives us prognostic information to say, if we give you the standard treatment, how likely are you to be in remission at 5 years, but also how likely a patient is to be alive at 5 years. Unfortunately, myeloma is a journey of peaks and troughs, and here you can see a rough outline of what's likely to happen with the protein levels in the blood. Some patients we meet have MGUS, or smoldering myeloma, and do not need treatment. But then at some point, some people progress, and the paraprotein will often be rising at this point and have other features such as fractures or kidney problems requiring treatment. So when we're assessing response, we look at a number of different factors in the patient's blood and bone marrow. So if the patient is producing a paraprotein or an M protein or a light chain, how quickly and what's the degree of change? And this is a surrogate marker for what is going on in the bone marrow to avoid doing bone marrows more frequently than we have to. So if the paraprotein changes by less than 25%, that's called stable disease. If it changes, if it falls to more than 25% to less than 50%, that's called a minimal response. Partial response is more than a 50% reduction in the paraprotein. And if your level falls by more than 90%, this is a very good partial response and telling us that patients are having very good remissions, and are likely to stay in remission for a long time. The gold standard is to achieve a complete response, and this is a combination of no detectable protein in the blood, including normalization of the light chain ratio, and no myeloma cells being detected in the bone marrow. But this is only the start of the story of response. And so what we can see above the water in terms of what's in the blood is only really the start of the response in modern myeloma therapy. And what we're trying to do, instead of chopping off the tip of the iceberg above the water, we're trying to go after the disease that's the iceberg that's hiding below the water to really drive very deep responses over time. And you can see here with the solid blue line, if you achieve a level of response that is MRD negative, i.e. you can't find any myeloma cells in the body, you're likely to stay in remission for much longer than if you're MRD positive at different levels, or if you're achieving different levels of biochemical response. And so looking at the iceberg, this happens to be a red iceberg on the right, you can see there's very different levels that we can go to detect how many plasma cells are in a patient's body. And new techniques such as mass spectrometry is a very sensitive way in which we can detect tiny amounts of the paraprotein in the blood that are invisible on standard testing. So another tool to avoid doing bone marrow is if we can detect disease in the blood. And then once you clear the blood, then you can look in the bone marrow, and it's not just can you see any myeloma cells in the bone marrow, but can you use very sensitive techniques such as flow cytometry, again using antibodies with a fluorescent marker and a machine that can count millions of cells to say, do you have any cells left in the bone marrow at that point in the area when the bone marrow was taken? Or can you identify a genetic sequence of the myelomas that's characteristic of a patient's myeloma? And again, look at millions of cells to try and see if you can see any cells. And these tests are sensitive to less than one in a million, but as we look at more cells, you can get this down to 1 in 2, 3, 4, or 5 million cells, depending on how many cells that you process. So I hope this has helped you understand some of the tests that we use and why we do them, and how we use them to talk to patients about what their myeloma is like, how this is going to affect them on a day-to-day basis, influence your treatment, but also try and modify your treatment to achieve the best results possible where we can't find any myeloma in your body. There are a number of resources at the Myeloma Australia website that you can go to help understand these tests in a bit more detail, and I hope this has been helpful for you.